Hello and welcome to today's tutorial on nappy rash. Nappy rash is a form of irritant contact dermatitis caused by several factors including skin maceration, prolonged skin contact with urine and feces, friction between the skin and nappy, and resultant increased skin pH. It is common in the first 2 years of life but particularly prevalent amongst 9 to 12-month-olds. The rash typically presents as well-defined areas of confluent erythema and scattered papules over surfaces in contact with the nappy. In severe cases, there may be skin erosions, edema, and ulceration. The child may appear distressed, agitated, or uncomfortable as the rash can be itchy and painful. Assessment. Ask about risk factors for nappy rash, including infrequent nappy changes, use of non-absorbent and non-breathable nappies, use of fragranced or alcohol-based wipes, diarrhea, and use of oral antibiotics. Ask about the location, nature, and duration of the rash, along with any previous episodes and treatments tried. The examination should look for oral candidiasis, which increases the likelihood of concurrent candidal skin infection and recurrent nappy rash. Features of candidal skin infection include sharply marginated bright red patches or plaques, and confluent zones of plaques and pustules that can spread into skin folds. In the case of bacterial secondary infection, there is likely to be marked redness with exudate. Diagnosis. Investigations are not normally required to make a diagnosis of uncomplicated nappy rash. Consider taking a skin swab if candidal or bacterial secondary infection are suspected, especially if nappy rash is severe. Treatment. Advise caregivers on self-management strategies that reduce or remove risk factors. These include increasing the frequency of nappy changes, using absorbent and breathable nappies, cleaning the skin with water or fragrance and alcohol-free baby wipes, and avoiding potential irritants. If there is mild erythema and the child is otherwise asymptomatic, a barrier cream should be recommended, and these can be bought over the counter. Steroid cream in the form of 1% hydrocortisone for 7 days should be prescribed in addition to a barrier cream if the skin is inflamed or causing discomfort. Prescribe topical imidazole if candidal infection is suspected or confirmed on a swab. Barrier cream should be withheld until candidal infection resolves. For suspected or confirmed bacterial infection, prescribed oral antibiotics, typically flucloxacillin or clarithromycin if penicillin allergic. Red flags and when to refer. Referral to a paediatric dermatologist should be considered if there is uncertainty about the diagnosis, the rash persists despite optimal treatment in primary care, or if there are recurrent and severe unexplained episodes.